Finley, and I'm your host for the ZOOMERTIMES TV, and I have a very special guest, a very busy doctor. In fact, he told me that he just got out of surgery, so we're lucky to have him. His name is Dr. Joseph Ricotta, and he is, he's something really important. He's a medical director in vascular surgery and endovascular therapy. Big words, important things. Why don't you just tell our lay listeners what that means? I mean, you don't fool around here.
Well, thanks for having me. Yeah, so I'm a vascular surgeon, and I fix the blood vessels. So we take care of problems with the blood vessels in the whole body. Everything outside of the heart is what we take care of. So blockages in the arteries, aneurysms, blood clots, things like that, stroke.
So how do those things happen? So let's just take someone who's healthy, and all of a sudden something happens. What happens to them and why?
Well, specifically, if we were talking about peripheral arterial disease, for example, or PAD, that's usually blockages from plaque buildup in the arteries in the legs. And what happens is the blood, takes the oxygen to the muscles and the tissue. And when there's a problem with the circulation and a blockage in the arteries, you don't get those nutrients and those oxygens to the tissues, and then you start to develop problems. Usually it starts with leg pain, and usually it's pain in your thighs or in your calves. When you walk, you get some cramping or discomfort or some tiredness in your legs. And then when you rest, it goes away. And when you walk again, it happens again. And that's because the muscles, when you walk, need a certain amount of nutrients and oxygen, and you're not getting that enough supply to meet the demand because you have a circulation problem.
And is this just in your limbs? Is that where you're going to feel it? Could it be somewhere else?
Well, you can rarely get it also in your arms and your upper extremities as well, but it's most common in your lower extremities and your legs. And the risk factors, people that develop this, which is the question you asked me, is most commonly in smokers. It only takes 100 cigarettes to do the damage to the arteries. So if you smoked in your lifetime, even if you've stopped, you're at an increased risk of having blockage, plaque buildup in your arteries. Diabetes is another big one, high blood pressure, high cholesterol, and then genetics, a family history of atherosclerosis, we call it, which is a fancy term for plaque buildup in the arteries. So those are the 5 main risk factors for people that can develop this.
And so if you go to your general practitioner, is he or she the one that's going to say, well, you're having a problem, I'm going to send you to Dr. Ricotta for examination?
That's quite common, seeing your primary care physician. They can usually elicit some of these symptoms of pain in the legs and things like that. And they might be able to do some basic tests at the bedside when you go for your physical to see if you have good pulses and good blood flow. And then if they're worried about it, then they would send it on usually to us for further testing. Usually the best way to check is with an ultrasound, sort of like when pregnant women get ultrasounds. You can put an ultrasound probe on the leg and you can look inside the arteries just with ultrasound to see if the arteries are clean or if there's some plaque inside of them. And you actually can look at the blood flow and you can measure if the blood how fast the blood flow is flowing through the arteries. And so that's a good non-invasive screening tool that we use in our office every day is an ultrasound.
Well, you're a young guy, so I'm going to get into some history.
Yeah.
50 years ago, if you were practicing, how would it have been different?
Well, yeah, 50 years ago, we didn't have all of these endovascular tools at our disposal. So technology has changed dramatically in the last 50 years. My father's a vascular surgeon.
How did I know that?
Yeah. And my grandfather, his father was a surgeon also. So,
my goodness.
When my grandfather was practicing 50 years ago, things were a little different. Most of it was treated with open surgery, so bypasses or opening up the artery and cleaning out the plaque or the blockage and putting the artery back together. So treating the arteries from the outside, so to speak, where we have to make a cut in the leg or somewhere in the body, cut open the artery and fix it. Now with the endovascular technology, endo meaning inside, vascular is vessel, so treating it from the inside of the vessel, we can do some really interesting things with just a little needle puncture without making a cut in any part of the body, just a little stick with a needle. And we can go in with a wire and a catheter and do the same thing that, you know, my grandfather did maybe 50 years ago. Now we can do it just through a little puncture. So the technology has really advanced quite a bit.
Less pain and faster recuperation.
Oh, yeah, big time. So usually these are outpatient procedures. They usually take an hour to an hour and a half. Patients recover for 2 hours. You know, they lay flat, so there's no, hematoma or anything from the puncture site. And then after 2 hours of recovering, they go home. A lot of these we can do in the outpatient setting in the hospital, but also in our surgery center in our outpatient setting. 50 years ago, or even to be honest with you, 10 years ago, you're talking about a big cut in the leg, 4 or 5 hour operation, anywhere between 3 and 7 days in the hospital before you could go home. Now these people get just one puncture and they go home in 2 hours back to their life.
So I've seen people with bandages all over their legs. So is that similar to what you're talking about, or that's more serious?
Well, that's probably people that have sores on their legs or wounds or ulcers. And so there's a spectrum for PAD, peripheral artery disease. On the early side of the spectrum, it's the leg pain that I described, which is called claudication, where you get some pain in your legs when you walk. And then you can progress to having pain in your legs at rest. Even when you don't walk, you get the pain because the blood supply is not good enough to meet the demand of the tissue, of the muscles in the tissue. And then on the furthest extreme, you can have what's called critical limb ischemia, which basically means if we don't do something quick, the patients might lose their leg. And that's usually people that have ulcers or sores or gangrene. And those are people that are at a very, very high risk of amputation. One of the things that we specialize in at Delray Medical Center is called limb preservation or limb salvage. And so we have patients from all over the United States come that are told that they need an amputation, and they come to us, and we usually are pretty good about saving their legs and preventing amputation by using some of these new technologies to fix the blockages and prevent an amputation. So every day we're doing some of those procedures. I got here about 4 years ago to South Florida. We actually decreased the amputation rate at Delray Medical Center by 86% since we started this limb salvage, limb preservation program.
That is spectacular. And I do want to talk about Delray Medical Center. It is becoming quite famous. You know, here in South Florida, we have a lot of hospitals, but so many people I know, even if they're in Miami, they're traveling up to Delray Medical Center because you have been establishing, as you said, some unique treatments. And the person you just came from surgery, of course, you're not going to tell us the person or anything, but can you just describe what happened with that person?
Yeah, so this person has actually a wound, as we say, an ulcer on the foot, and had seen a couple of other doctors at other hospitals who tried to fix it and improve the blood flow, but they couldn't do it. They said that nothing could be done, and the patient needed to have an amputation at the level of the knee, And we were able to get through the blockage and fix it. And so it looks like we're going to be able to prevent that amputation. The patient should heal up just fine.
Now that's a miracle. I don't want to call it a miracle. You know, we don't like to say miracle, but it really is major that you could do something like that. You shouldn't be on the show now. You should be home having a glass of champagne. That's very exciting news. I wasn't aware until you really started talking about this, how I thought, you have spider veins, you have, all sorts of veins on your legs. I didn't know all the things you've just shared with me.
Yeah, I mean, spider veins, we take care of spider veins too. I mean, spider veins are more of a cosmetic problem. Varicose veins and what we call venous insufficiency is not cosmetic. It's more of a serious medical problem, but not as serious as somebody that might have PAD where they could lose their leg. So, the nice thing about vascular surgery, and one of the reasons I went into it, is that you get to take care, because we take care of all of the blood vessels in the body, you get to take care of a lot of different problems. And so aortic aneurysms or stroke from the carotid arteries, or the legs like I talked to you about, varicose veins, venous insufficiency, kidney problems. So we get to take care of a lot of different things. So every day I get to do different types of operation. There's a lot of variety. So it keeps things interesting for sure.
Is your father still living?
Yeah, my dad is still practicing in Washington,
He must
D.C.
be so proud of you.
Yeah, he's in D.C. and he was the chairman of surgery at Georgetown there.
And then
He's
having your grandfather. Well, you really are a lucky kid, and they're lucky to have you.
Yeah, well, I appreciate that. Yeah, I grew up carrying my grandfather's black bag with him to house calls when he made house calls. So that was in Buffalo, New York. So he used to see his patients in their homes, and I was probably 6, 7 years old, and would go with him and carry the bag and sort of sit in the corner and be quiet. So I got to learn a lot from him from a young kid about taking care of patients and the impact we can have on people's lives. The one interesting story is, since I moved down here to South Florida almost 4 years ago, I've had several patients coincidentally 40, 50 years later come into my office for vascular problems that were my grandfather's patients 40, 50 years ago. Because he sort of did everything. He delivered babies and did general medicine and everything. So they come in and they're like, your grandfather delivered all of my children. I was his patient. And some of them remember me because he had his office in his house, because back then that was very popular. So one part of his house was office, patient exam rooms. And as a kid, I used to, I guess, make a lot of noise running around there. So they remembered me as a kid disrupting my grandfather's office hours. And now they're in my office as my patient. So that's pretty unique.
Was his name Joseph Ricotta?
Yeah, I'm named after him, actually, yes.
Oh, you are? What's your father's name?
John.
Oh, okay, well, the J. So Dr. Joseph Ricotta, the specialist many years ago, they come down, they say, well, you're not Joseph. No, but I'm his grandson, right?
Right, exactly.
Well, I want you to go back to the Delray Medical Center. You said that sometimes it's outpatient, it's inpatient. What makes the difference? Why do you have to be in the hospital as compared to just doing it in the out clinic?
Yeah, that's a good question. Most of the endovascular procedures that we do, like I talked to you about, fixing things from the inside through a puncture, almost all of those can be done outpatient because it's a minimal impact on the patient physiologically. So just a little needle stick. So after we're done and we fix everything from the inside, they can go home. The people that have to stay overnight are either the people that may be a little bit less healthy, higher risk factors and more medical problems, and we want to keep an eye on them and make sure that they're safe before we send them home and watch them overnight. Or if people, we still have to do surgery on some people. Not everybody can have the endovascular approach. I would say in my practice, it's probably about 90%, 85, 90% endovascular and 10 to 15% open surgery. So we still do some open surgery, and those patients need to have a little bit of a longer hospital stay. So that really differentiates between outpatient and inpatient, but probably 85 to 90% of what we do is outpatient nowadays.
That's terrific.
Well,
so are there things that you can tell our audience that they could do to prevent this? Is it diet? I know you talked about smoking, but is it diet? Is it exercise? What is it?
Yeah, that's a good question. So it's really about controlling the risk factors. So smoking, number one, it's easy for me to say, but you have to quit smoking. And what I tell patients a lot of times is I'm not going to operate on you unless you've quit smoking, because whatever I do, if you keep smoking, it's going to fail and we're going to be right back to square one. And you have to, take that responsibility and get your mindset that you have to stop smoking. So that's number one. And then the other one is controlling risk factors. If you have diabetes, make sure your sugars are in good range. If you have high blood pressure, make sure you're on medications that your blood pressure is controlled. Same with cholesterol. There's not much we can do about our genetics. So people that have, genetic predisposition to atherosclerosis, you can't do much about regulating that. But those are the things. So we always put patients on what we call best medical therapy, which is cholesterol medicines, blood pressure medicines, diabetes medicines. And then we help them try to quit smoking. And that's what patients can do for themselves. Now, if patients don't have PAD yet, or if they have PAD and they don't have any symptoms, if we can get those risk factors under control, then the disease doesn't necessarily have to progress down that spectrum that I explained. And hopefully patients never need any procedures done and we can control them medically. But for those patients whose disease progresses despite the medical therapy, those are the patients that we have to intervene upon. And again, most of them can be done endovascularly with this minimally invasive approach from the inside. As a surgeon who can do both the endovascular procedures and the surgery, I always have a surgery backup plan, a plan B or C, if you will, so that if the endovascular plan A doesn't work, we still have other options for the patients to get them over the hurdle, so to speak. So it's nice as a vascular surgeon who can provide sort of all-in-one care for these problems, that we have multiple different ways to treat the patients.
So are you using robotics in a way so that you can see what's going on as you're doing this?
Yeah, you must have been doing your reading a little bit. Yeah.
Well,
So
I'm a gerontologist. I've been doing this a long time. And so I always look up things ahead of time. I've looked you up. I saw what you did, but robotics is, people don't understand. It's not like a robot comes in there. It just makes your life easier. But why don't you explain that?
Sure, yeah. So, endovascular robotics is really the way of the future, in my opinion. And so a lot of people are familiar with surgical robotics, the Da Vinci robot, where people and surgeons now are using a robot to help them be more precise with open surgical, laparoscopic surgical procedures. They have the same thing on the endovascular side. So there is a robot that can help you control the wire and the catheter when you're inside of the patient's blood vessels, and give you a lot more precise control over things and help you navigate complex anatomy, turns and twists and blockages very much more easily with the robot. So we actually, at Delray Medical Center, we have an endovascular robot. We did the first endovascular robotic case in the United States, in the whole country.
Really?
In early 2018, I think around February 2018, so a couple of years ago. We've done more endovascular robotic cases than anybody worldwide. So nobody else in Florida has an endovascular robot for vascular disease. And we do a lot of robotic cases. And again, the advantage of the robot is it allows you more control and precision over the wires and the catheters than if you're just using, your hands. Because, human error is human error. So the robot takes that out of the equation. So we do a lot of our procedures using the robot.
Well, Dr. Joseph Ricotta, it's so wonderful to have you on the show, because people who are watching this, they're going to want to come to Delray Medical Center. They don't want to go somewhere where it's just, it's another operation. You really have it, you have it taken here. And I wasn't aware of this. I'm so glad that you were coming on our show. And I mean, I love the folks at Delray Medical, but you're a star, I guess. Are you conceited?
I try not to be. My
father and your grandfather, they wouldn't let you have that.
No. Well, definitely my wife and kids won't let me. That's for sure. So that's for sure. But one thing I would say about Delray, I came down for a reason. I trained and worked at the Mayo Clinic and the Cleveland Clinic and Johns Hopkins. And Emory and some top institutions around the country. And one of the reasons I came here, besides helping to build a program, was because I saw the tremendous opportunity to treat vascular patients. I feel like in South Florida, vascular disease is a little bit underdiagnosed and undertreated. And I saw the commitment that Delray Medical Center and Tenet Health were making to developing a center of excellence from a cardiovascular perspective. And so I really have to tell you that they've done everything they said they were going to do when they were recruiting me to come down here, and they put their money where their mouth is, so to speak, and built a $7 million special vascular operating room for us, and have attracted some of the best and brightest doctors and staff to help run the vascular service line. Have always said yes when I asked them for more equipment and technology, and have been very supportive from that standpoint. So I would agree with you that in my mind, Delray Medical Center is the place to be in South Florida, if not in the whole state of Florida, not only for vascular work, but in other service lines. They've made a big investment on the cardiology, cardiac side, on the oncology side, on the orthopedic side. So I think the people in South Florida are lucky to have Delray Medical Center, in my opinion.
Lucky to have you. I mean, you're doing more PR than even their PR agency. So you've done a great job. Well, it's obvious you're very proud of this, and you've shared so much that I wasn't even aware of. I've only been aware lately that heart patients are running to the Delray Medical Center because they have also conquered a lot of things. But I want to go tell people that in order to have this happen took a lot of money. I know that the Da Vinci itself, just having that robot, it's a lot of money that an organization has to put up front. So getting you and getting all that, they are very serious. And that's a Tenet hospital?
That's a Tenet hospital, yes, ma'am.
Mm-hmm. Well, this is a really terrific. So, the ad that you all will be running in our upcoming issue, the headlines, do you have leg pain? Everybody has leg pain, it seems like, but it's not all caused by what you do. It could be.
No, that's right. Yeah. So it's not all leg pain is vascular related. Some of it is nerve related, neuropathic pain. Some of it is orthopedic related, muscles, muscle aches or joint pains, arthritis, that kind of thing. So, one of my jobs is to figure out when patients come with leg pain, is it a vascular problem? And if it is it something that can be fixed that I can help relieve the symptoms? I do have patients that come with leg pain, and we test their blood vessels and they're okay. And then we say, cross that off the list. It's not a vascular issue. And, let's go down the differential diagnosis and figure out what it can be. So I'm always happy to see a patient with leg pain. And even if it, is not a vascular issue, at least we can rule that out for them. And then they can go down the list to figure out what's causing it. But a lot of people that have leg pain do have vascular problems, whether it's in the arteries, like I described, or in the veins.
Well, Dr. Ricotta, though, something we didn't get to talk about, I mean, you did this very quickly, and I'm going to definitely ask you to come back again. I want to talk about people with stroke, because that's all part of what you're describing, right? How does someone have a stroke? Why do they have a stroke? And I know that you have a lot of stroke patients that go to Delray Medical.
That's right. Yeah, we are a stroke center at Delray Medical. A lot of strokes are caused by blockages in the carotid arteries, so the artery in your neck that goes to your brain. Probably 35 to 40% of strokes are caused by blockages in the arteries. So that's one thing that I do, that we do in vascular surgery, is fix the blockages in the carotid arteries. We actually, again, talking about technology, and another example of how Delray has really invested in the newest and greatest tools to treat these patients. We do a new procedure called TCAR, TCAR, and that's a new way to put a stent in. Instead of going through the groin, we go actually in through the neck and we put a stent in. And we were the first about 2 years ago to do it in South Florida, the TCAR procedure. And we've probably done more than anybody in the United States of these procedures. And the real benefit from it is that the risk of stroke for a stent that you put in through the groin, which is sort of the old way to do it, is 4%. And the risk of stroke with surgery, where you clean out the blockage, is 2%. but the risk of stroke with TCAR, which is this new procedure, is 1%. So
TCAR
technology keeps, I'm sorry?
What does TCAR stand for?
TCAR stands for transcarotid artery revascularization, TCAR.
Yeah, I knew you would know that. I have to be careful when I ask people because when I do interviews, a lot of times people come with all their notes, but you're so smart. I'm sure you knew that. So that's very important with stroke, and then getting to the hospital quickly enough, right? And then having all this done. So we're not having as many stroke patients who become more or less paralyzed. Then you're able to treat this and they can go on with their life.
That's right. And also we do a pretty good job of screening these patients. So, you know, all stroke patients at some point were asymptomatic, but they had a lot of blockages in the carotid arteries. And then it got to a point where, you know, they had a stroke. But if you can catch these patients early, and again, it's usually with an ultrasound on the neck, just like pregnant women, we would do it on the neck. We can look inside with the ultrasound and see the blockage. And if the blockage is a certain level, 70, 80%, we usually try to fix those patients prophylactically, preemptively, to prevent a stroke, because if you wait, then the patients have a higher risk of having a stroke. And so again, getting screened for carotid disease is important. It's the same risk factors as the leg, as the PAD, cholesterol, blood pressure, diabetes, smoking, family history. And so we do screenings with ultrasounds in the office to make sure people don't have blockages in their neck arteries that's severe, that we can fix ahead of time and prevent a stroke, because the whole idea is to prevent the stroke from happening in the first place. Okay. But if unfortunately they'd have a stroke, again, Delray Medical Center, in my opinion, is the place to be. They have a great team. The stroke team is excellent. And we have a great multidisciplinary team there. So it's just another service that Delray is offering to the community.
Well, they were very fortunate to find you. And also, I was going to ask you a strange question, because I've done this with a lot of physicians. Did you love your cadaver?
Yeah,
you know, I asked that because you just think about that. I don't know, it's your first year of medical school or something. And the reason I say is because I have dedicated my body, as long as I don't have some sort of disease they don't take, to be a cadaver, because I want to help when I'm gone. And I've heard wonderful stories about cadavers and how doctors feel about them. But you had to practice on a cadaver, all the things you're talking about.
Yeah, you know, it's a special thing when somebody donates their body for the advancement of medicine. And so, you know, I was always humbled when I would go into the anatomy lab that this person did this for us. But I was probably the medical student that was in there hours and hours after, you know, the class was over, dissecting things, because I just was drawn to that. And like I said, I sort of grew up around surgery with my dad and my granddad. And so I love my anatomy class in Thomas Jefferson in Philadelphia. It was a great time. Yeah.
You know, and I've heard, I don't know if it's true, but I've heard that after the class is over, that everybody has a celebration for the people who are still around, the cadaver. Yeah. You know, because they need more cadavers. I'm kind of pushing that now for people to think about it. But you did learn a lot from your cadaver, didn't you? Oh,
yeah. Tremendous. Yeah. And you cannot, no matter how much, you know, you work with computers and simulation and things like that, you can't beat having something real and tangible to dissect and learn from and practice on. It just, you can't substitute something like that.
2 minutes.
And so it's your, I gather you had some children. You say you have children?
I have 3 children, 16, 14, and 12 years old. Yep.
Okay. And are they thinking about being doctors?
It's interesting. My youngest one, so it's a boy, girl, boy. So my youngest son is 12 years old, and he is very interested in anatomy, and he learned anatomy in school. And actually, when he was in 5th grade, he's just started 7th grade now. But when he was in 5th grade, I was a popular dad, because they studied the heart in biology class in 5th grade. And I was able to bring in some beating cow hearts, animal hearts.
Fantastic.
And we brought them in these little chambers, and the kids got to see the hearts, and then they got to dissect it. And so we had a little show and tell in the classroom. But in fifth grade, he was 10 then. My 10-year-old was reciting all of the anatomy of the heart and the valves and the chambers. So if any of them are going to be surgeons, it's going to be him probably.
Oh yeah, I bet he got an A in that class. That's very exciting. You know, it's funny. Before the COVID, we actually did what we call cure symposiums, cure medical symposiums, and I had brilliant doctors like you, about 12 of them, this whole day. And when we bring them back again, you're on my list.
Yeah, well, I appreciate it. Happy to come back anytime.
Yeah, because we're going to have you back because you're, you've said so many things today where our listeners are just, kind of on the edge of their seats. See, we don't get a chance to talk to doctors like you very often. You go to see a doctor and you have a time limitation. So we're very privileged for you to give us the 30 minutes you are, because people want to know, especially now, so they get on Google and all, but it's not the same to have a living, breathing heart.
Right.
Talking about this. And I'm sure you become so fond of your patients, and they look at you and they say to you, well, what do you think I should do, right?
Of course, yeah. And, I treat every patient like I would my own family. That's what I tell them. If you were my dad, this is what I would do. If you were my mom, this is what I would do. And I learned that compassion and the way to approach patients from my dad and my grandfather. Yeah,
well, it's wonderful that, and your dad is practicing, and so does he know how good you are now? Does he realize the hospital that you're at and what you're doing? I guess he encouraged you to come here.
Yeah, he knows. I mean, the funny thing is, he's also a vascular surgeon, so we're in the same field. And he said to me the other day, maybe about 6 months ago, he said, it used to be that people would go up, and his name is John, right? It used to be that people would go up and say, you're John Ricotta's son. They would come to me because my dad is a pretty well-known vascular surgeon. You're John Ricotta's son. And now they go up to him and say, hey, you're Joseph Ricotta's dad. So,
that's good. Yeah, that's right. So the family, well, it's unusual. I mean, I've heard of medical professionals having a family member, but to have three doing a lot of the same. So, and of course it's grown now, as you said, when you were before, you were watching, your grandfather carrying his bag around, or your father. But, well, you know what? I think we've run out of time, haven't we, Dan?
Yes, unfortunately.
Oh, isn't he great? We're going to have Dr. Ricotta.
Oh, my gosh. Yeah.
Dr. Joseph Ricotta, MD, MS, all the credentials, Regional Medical Director, Vascular Surgery and Endovascular Therapy. Big words, but he's a big guy. He's smart, and we loved having you, Dr. Ricotta. Thank you so much.
My pleasure.